Okay, I think we're great. Thank you very much for the wonderful introduction and the really kind invitation to present to this group today. I think this is such a wonderful seminar series. I'm really pleased that I can be here with you virtually. Thank you for making it just a little bit earlier in the day so I don't have to be up in the middle of the night in Australia. So I'm going to talk today about some different methods that we have for measuring and tracking circadian changes in humans. And hopefully by the end, if you're not already convinced, you'll be convinced that we should be measuring this quite broadly and in lots of different contexts, and can see some of the ways that I think we'll be developing scalable and personalized approaches to do this. So our bodies are made up of clocks that regulate the timing of essentially every biological, physiological process in the body. We have our central circadian clock located in the SCN in the brain that is synchronized to our 24-hour solar day, primarily by exposure to light. When our circadian clock becomes misaligned with the solar day, we see circadian disruption. We have broad consequences for health and performance that comes along with this, things like trouble sleeping, dysregulation across physiological systems like our metabolism. We have trouble with alertness and cognition. And really what we're talking about here is disruption that can occur at multiple different levels. So we can have misalignment between endogenous timing and our environment and our behavior. And we can also have disruption within the endogenous circadian system itself, so misalignment between peripheral clocks and the SCN. And we can see really clear examples of very frequent circadian disruption in shift workers. Most commonly, they are often required to work against their biological clock and so frequently are exposed to circadian misalignment. And we also see examples in sleep disorders with extreme cases like non-24-hour sleep-wake phase disorder, which I've represented here, which is effectively a failure to entrain to the solar day. And we see this across different conditions as well. So for instance, if you travel across time zones and you experience jet lag, you're in a state of circadian disruption. And we see this kind of disruption links to a wide range of negative outcomes across our cognition, our emotional regulation, and in our health, we see increased risks of cardiovascular disease, diabetes, gastrointestinal problems, immune disorders, cancer. And we really think these relationships are likely to be bidirectional. So circadian disruption likely increases our disease severity, and also many diseases likely disrupt our circadian rhythms. But for us to really be able to piece all of this together, we need to be able to measure the clock in humans and track this kind of disruption broadly. So we need to measure the clock in humans for a lot of different reasons. I'm just going to give you a few examples. One being to better understand the system. So in our experimental studies or our field studies, we need to be able to measure circadian timing to understand the properties of the clock, what happens when it's disrupted in different contexts, how our central clock time relates to peripheral clocks and the regulation of other physiological systems like our sleep, alertness, mood, mental health, cognition, disease states, etc. And this is especially important given the likely bidirectional impacts on health and disease. There are also a large number of examples where having a measure of the clock has direct applications for health and safety. So for instance, it's highly recommended for a lot of sleep disorders that you measure the central circadian clock to help inform your diagnosis. However, this is very rarely done clinically for reasons that will probably become clearer when I talk a bit more about how we measure the clock. But part of why this is so important is that we see different phenotypes that emerge that present very similarly if you go by sleep complaints. So we see often, for example, a lot of overlap with complaints related to delayed sleep phase disorder and insomnia. Often the sleep complaints are trouble getting to sleep, trouble staying asleep. And some will have circadian misalignment, so they're attempting to sleep at an inappropriate biological time, and then others don't. So on this figure here, if you can see, I've got melatonin onset time relative to typical sleep timing across a range of different conditions. And you see that there's quite a bit of variability with some attempting to sleep out of phase and others not. And really this indicates different treatment approaches that you would take. So without measuring the clock, it's quite difficult to know if you need to treat circadian misalignment, or if you need other interventions that might be more appropriate. Measuring the clock is also very important for our chronotherapies, such as light therapy, that are phase dependent. We know from our phase response curves that the biological time you administer light will determine the direction and magnitude of the phase shift that you induce. So for instance, light before our core body temperature minimum will delay the clock, and light after core body temperature minimum will advance the clock. So if you don't measure circadian timing, you don't know when to apply the therapy to get your desired effect. And this is likely true across a lot of other chronotherapeutic applications across medicine, which will be based on their own phase response curves as well. And similarly, we're often very interested in measuring the clock in occupational shift work settings due to the known rhythms in alertness and cognitive performance that make working during that biological night a time of high accident risk. So evaluating the risk, developing fatigue management plans, creating personalized interventions for shift workers all benefit from knowledge of a person's circadian timing and when they're likely to be most at risk. And for all of these use cases, we do need to measure a person's phase. It's not advisable to just guess because we see really large variability in circadian timing across individuals. So we see this here in this example on very consistent regular sleep schedules in people who are sleeping at night and otherwise very healthy, shown here with our melatonin onset relative to sleep in data from Dr. Tracy Sletton. And it's exacerbated even further in situations like in shift workers. I've shown you here urinary melatonin phase in shift workers that we measured on day shifts, and then we tracked those same individuals onto night shifts, where we see larger than a 6-hour range in phase amongst people that were all working the same schedule. And then this next panel here is showing variability, basically the same data, but variability in how their circadian timing changed. So we saw very big differences in the direction of change, whether they delayed or advanced, and by how much. So not only do we see large variation on day shifts, but there's also a lot of variation in how much people change day to day as they move across the same circadian challenge onto night shifts. And so therefore, if we don't know someone's current biological time, it's very easy to apply our chronotherapy at the wrong time for that person, which can make it ineffective or even counterproductive. Excuse me. And it also means that our biologically at-risk times for alertness is highly varied across the workforce, even on the same rosters. Unfortunately for us in humans, we can't directly measure the central clock in the SCN as much as we might like to. So instead, we measure marker rhythms with really well-characterized, reliable endogenous rhythms and look at particular phases as our marker of central circadian timing. So I am going to focus primarily on melatonin going forward, as it's got a very robust rhythm that's very commonly measured, but we can look at other robust rhythms in other hormones like cortisol and in core body temperature, where we're looking for markers of the biological night. So on this plot here, the biological night is shown in gray. So we're looking for markers of the onset and peak in melatonin timing as a common phase marker, or the core body temperature nadir or minimum. There are a number of ways that we can measure these rhythms, with the primary consideration really being to ensure that we're measuring the endogenous SCN-driven rhythm in our variable of interest. So one of the cleanest ways to do this is using what's called a constant routine protocol, where the goal really is to hold constant any masking variables to measure that endogenous rhythm for at least one full cycle. So commonly this would involve someone coming into the lab with regular sampling for at least 24 to 48 hours. Sometimes there's sleep in the lab beforehand. I've shown just an example in a raster plot here where someone would wake up in the lab and then do a 30-hour constant routine. And what you'll notice is the primary takeaway is that everything is very regular. It's in very dim lighting. There's very regular saliva sampling in this case. There's usually a core body temperature measurement via a pill or a thermistor or something like that. and very regular snacks. Everything is very consistent. So in terms of procedures, it's fairly simple and repetitive, but it can be quite harsh on participants. So maintaining a regular posture is an important control for these measures. They need to remain in dim lighting. Most cases we would do less than 10 or less than 3 lux. But given the high variability and the sensitivity to light we see, going at as low a light level as possible is going to be safer to avoid any melatonin suppression effects from light, so less than 1 lux ideally. Controls over food and drink intake and remaining awake all the way through. So it's quite harsh on a human to sit through this, but when you do, you get a really beautiful full profile of an endogenous rhythm, and we can then fit a curve to find the peak time. And with melatonin in particular here, we can look at our secretion onset and offset times, and we can look at the amplitude of the rhythm as well. We can also look at measuring a partial profile. So particularly in melatonin, it's very common to measure the dim light melatonin onset or DILMO time. This only requires sampling for about 7 hours to capture the melatonin onset or rise in the melatonin levels. That's quite well characterized, considered a gold standard way of measuring circadian phase in humans. So to measure this, again, we must keep our controls very carefully in place. We need to make sure that we're measuring the endogenous rise of melatonin free of masking factors. So again, very dim lighting, regular sampling, usually hourly, and saliva, you could do half hourly. Making sure there's no food or drink before each sample to avoid any contamination or dilution of the samples, avoiding medications that can affect melatonin as well, so things like beta blockers and non-steroidal anti-inflammatory medications. Typically with this kind of assessment, we would sample from 5 hours prior to someone's recent habitual sleep onset time to 1 to 2 hours after, really just to maximize our chances of measuring that melatonin onset, which is usually in the couple of hours before sleep here. However, caveats, timing this correctly can be tricky if people aren't free to choose their sleep times, or if sleep is irregular or misaligned, which means we can't always predict where their biological night is based on their sleep timing. So just to illustrate that as an example, if someone's sleeping well out of phase, so for example, if we have a shift worker who's sleeping during the day, if we're basing our sampling based on when they're sleeping, we run the risk of sampling at the wrong time in their rhythm, and you miss that melatonin onset in this case. So in some cases, it's a better bet to do a full profile, particularly in cases like shift workers where there's large variation between people in where their endogenous rhythm is relative to sleep. We can also measure DILMO in home settings, which is often quite appealing for clinical populations, or indeed necessary in times where you can't get someone into the lab. Perhaps they live far away, or perhaps you, like us, during the COVID lockdowns found that you couldn't bring people into the lab. So we had to very rapidly adapt protocols on a longitudinal study that we were running in teenagers, where we were measuring DILMO in up to 30 teenagers at a time in the lab, and obviously could not do that during lockdowns. So we had to transition that to be entirely remote collections. Doing this, you have the same controls required to ensure you get that nice clear measurement. So making sure things are really dim in terms of the light levels, you're controlling your meal intake, posture, but with, of course, some extra challenges of making sure that that's feasible in someone's home. So things like putting together a kit with really clear instructions, making sure participants understand what the controls are, making sure you get their buy-in so that they're willing to do what is a fairly unusual task of sitting in the dark and spitting into a tube. And there are things to consider as well about how you make sure that the lighting is dim enough, things like if there's blinds available, deciding if you'll allow a dim laptop screen for entertainment. We find that's usually okay if the room is otherwise very dark. It's a very dim screen with a blue light filter at least a meter away. And you also need to think about compliance. So things like making sure that you get the samples collected in the right tube, in the right order, that they're collected at the time that you want, making sure that there's compliance with the dim lighting all the way through the assessment and some of your other controls. So there are at-home protocols that have been around for decades now. And there's often new innovations that can help make this easier for participants and for us for checking compliance. So things like time-stamped sample caps exist now. There are light monitors we can use to measure light continuously through collections. You can do site visits to help set up, or like us during lockdowns, we used video conferencing to kind of help everyone set up. We stayed online in that case with our adolescents just to really guide them through the sampling times and making sure compliance in real time as well. And you can always come up with different innovations as well as around trying to make sure things are dim as possible in terms of lighting, like these very stylish goggles I have modeled here, that you can use to help reduce light if participants have to use a bathroom in a shared space that can't be made dim, or perhaps it's summer and the room is too bright for the early couple of samples before the sun goes down. So there's lots of ways that you can get creative and try to help make the collections a bit easier for participants to do. However, sometimes you do need to do a full profile. So for example, when you're not sure when to sample, or if sitting in the dark for 7 hours isn't going to be possible, another option is to measure urine for 24 to 48 hours. And from this, we can assay 6-sulfatoxy-melatonin, which is the primary melatonin metabolite, and we can look for the peak timing there as well. So with this approach, you do get lower time resolution. The sampling is usually every 4 to 8 hours, but there's much fewer controls required for the person collecting it. They can collect the samples as they go about their lives. They can sleep, they can eat, they can do all sorts of normal activities. They just have to make sure that they're collecting all of their urine. So this approach has been used successfully to detect rhythms in a lot of different shift workers in operational settings, in cases of non-24-hour sleep-wake phase disorder, and in some really remote settings like in Antarctica as well. So even though I do think we still need to be using these approaches to measure circadian timing as much as possible in our studies and hopefully in the clinic, there are some quite significant challenges that hold us back with some of these approaches. Some of them you might have already put your finger on. So these assessments are quite expensive, both in terms of money and time and resourcing. Assays and equipment always are going to cost money. It takes quite a lot of time, even if you're doing a shorter DILMO assessment, both for your researchers or your technical staff and for the participants or patients that are doing the collections. Most of these approaches involve sleep deprivation to some degree, so we do have to consider participant burden depending on the context. And it also means that our sample sizes are often constrained by cost, and clinical assessments are rare. So there's definitely no rebates or insurance that I'm aware of, definitely not in Australia for circadian assessments, and probably not elsewhere, although I'd love to hear if anyone's managed to get that on some kind of rebate system. Even though the evidence does point to it being very useful for diagnosis, few clinical services offer it. There's also a lot of trouble, at least for us in Australia, getting real-time results. Most of the assays are done off-site, and they can take weeks to months to get results back. So while that might be okay for research studies where you're collecting a lot of information and we can go back and relate it to other measures, in the clinic or in cases where you want to really use that circadian phase information for some biofeedback or to time your interventions, this really is too long to get results, especially if by the time you get the results, that person's phase might have moved as well. And so this leads to difficulty tracking changes in phase over time. So we're quite limited in how often we can measure phase, even in our research studies. So we don't know a huge amount about day-to-day changes in phase in the real world. And it's not particularly practical to track long-term in the way that we'd love to get a really good understanding about the long-term dynamics within a person, and also for informing our chronotherapies in real time. So for that day-to-day precise circadian medicine. So we do need practical alternatives to track individual level circadian phase long-term out in the wild. And there are a lot of people looking to the data that is often being passively collected all the time via wearables. So I'm going to spend the next part of this session really talking about other approaches for tracking circadian phase, particularly focusing on those model-based tracking using wearables that some of you be wearing today, tracking all of your light and your heart rate and your body temperature. I will note that there are a lot of people much smarter than me working on various omics-based approaches for things like single sample or 2 time point assessments of phase markers, which I think are really cool, very exciting, but not in my area of expertise. So today I'm not going to go into them. I'm really going to focus instead on ways that we can make use of those passive sensors that a lot of wearable devices already have or are starting to have. Many of you might be wearing them today. So what these approaches really do is they take inputs recorded using the wearable devices. So it might be research devices like actigraphy, our various light pendants. It might be consumer grade devices, and they're input into a model that will generate a daily estimate of circadian phase. So I'm going to take you on a little bit of a tour of some of these approaches. And as we go through, I'd like you to keep in mind what I think the model needs to be useful. It needs to be simple and non-invasive for the participant. So we're talking passive sensors that are easy to wear. It needs to be able to predict circadian timing changes over time and in real time. So it needs to be dynamic. It needs to be accurate at the individual person level, not just the group average level. It's not particularly helpful for aiding a diagnostic decision or a treatment if you have a model that isn't accurate enough for the person that's in front of you. And to that point, it needs to be well validated in a wide range of settings against reliable phase markers like melatonin so that we can be confident that the model is giving us an accurate assessment. Various approaches have been taken to modeling circadian phase from the various inputs we can track from our behavior, our physiology, and our environment like light. The simplest of these use statistical linear regression type approaches where you can take a single variable or a combination of different variables. They might be from a questionnaire like a diurnal preference type measure. They might be calculated from average sleep-wake timing or light exposure over a few days or a week. And they use them to predict phase based on a linear relationship. Some of these approaches give quite reasonable estimates or explain the variance that we see in phase in specific settings, but they don't always generalize. So for example, if we look at sleep timing or chronotype, it can be a poor proxy for circadian timing, particularly in cases of circadian misalignment where people are sleeping out of phase. And so increasingly what we're seeing is a lot of new machine learning based approaches being applied to predict either melatonin rhythms or core body temperature rhythms. These can be static approaches, so predicting a single phase value at a single time point, or they can be dynamic, so predicting rhythm profiles, taking really continuous time series input. This is a very data-driven approach, so you don't tell the model anything about the system or how it works. You train it on a lot of data. Typically, the data that is used for these approaches is collected in very controlled, quite entrained conditions, and they haven't been very well validated across field settings. So for one example, when I tried to replicate one of these approaches, it didn't generalize very well to cases of circadian misalignment like our shift workers. And probably we shouldn't have expected it to. They're not trained on broad enough data at this point to really be able to generalize across that kind of complexity. And then there are physiologically based models that represent the circadian pacemaker as a limit cycle oscillator with variations in phase and amplitude related to changes in Zeitgebers or time cues, particularly light exposure. So this is a dynamic systems type approach. You can input continuous time series data of light or sleep-wake timing to either track circadian phase over days or to forecast phase dynamics given a particular light pattern. And so this is the focus today. This is the type of model that I'm going to talk a little bit more about. Limit cycle oscillator models of various forms have been used to simulate the dynamics of circadian clocks and their response to time cues, both in human and animal models over the past decades. And the ones that we use today were developed in the 90s by Dr. Kronau and his team. And effectively what this model does is it represents the circadian pacemaker as a limit cycle oscillator. It will oscillate with a fixed period in the absence of external stimuli, very much like what our internal clock will do. And then because light is our key synchronizer of our circadian pacemaker, we can input this information into the model to produce a phase change. So the model oscillations can be modified, they can be pushed into longer cycles or shorter, depending on the timing and the strength of the light stimulus. So the oscillator model we use today has been systematically tested and refined using experimental data examining the effects of light intensity, timing, and duration on the phase and amplitude of the clock. I will note that this was developed before we knew much about melanopsin, so there is probably some refinement in particularly some of the photoreceptor sections of the model that we could do, but it has held up remarkably well at describing the properties of phase shifting as we see them in the lab. So light is our primary input into the model. We can measure this using our light sensors worn on the wrist or around the neck, or maybe by some new technologies or on glasses, or if someone's somehow developed a contact lens with a light sensor, I'd love to hear about it. But this light information will feed into a simple model of retinal photoreceptors, which is altered by a stimulus modulator depending on the current phase and amplitude of the oscillator. And that will produce a drive on the oscillator to either slow down, so cause a phase delay, or to speed up, causing a phase advance. So this model predicts the core body temperature rhythm, but it's also been used to predict other phase markers like DILMO. And a non-photic component has also now been added by Dr. Saint-Hilaire, who I believe was speaking to this group last week, meaning that sleep-wake data can also be used as an input into the model. And there's some evidence emerging that this might improve model accuracy in field settings. So this model has now had much more validation in real-world settings to track phase compared to a lot of other approaches. And there are a number of cases now that we can look at in different population groups where the model predictions have been validated against melatonin phase markers. So I plotted here the mean and absolute mean errors from a number of different published implementations of the model where the model was performed, was evaluated against melatonin phase. I am sure that there's probably more recent tests that I'm missing here. Indeed, I hope that there are. So please take this as representative rather than a complete list of all of the cases that have been published. But what we have here are examples where light and sleep information is predicting phase collected under normal living conditions on regular and irregular sleep schedules, also in shift workers, both on rotating schedules and on permanent night shifts, and also in some clinical populations, so looking at delayed sleep-wake phase disorder patients. And what we see here is that the model performance at the group average level is fairly consistent across. So the average error is close to 0 in most of these cases, indicating no particular bias either way in the estimates. And the average absolute errors in green here are sitting around the 1 hour mark or just under, with higher errors in cases with larger variability in sleep. So this kind of testing, I think, is really important for validating the model for use in the field. Predicting phase on a really regular sleep schedule in very healthy screened populations is quite an easy test case, really, for the models. The inputs and the phase markers are quite well aligned, so it should work fairly well. But when we look at models in cases where there's considerable misalignment between our sleep timing and the endogenous rhythms, like in night shift workers, it's really a much more challenging test case for the models. So it's promising to see that the results remain fairly consistent across a number of these settings. It is important to note, however, that the model has varying success capturing the individual variability and phase across these settings. There's often quite large standard deviations around the error in both directions, and I haven't put the R-squared values here, but they do indicate that there's room for improvement. We're not quite capturing the individual variation we see in real-world contexts. So how can we improve this problem of model individualization? And by that, I mean, how do we make sure that the model is accurate for the person or patient that's in front of you if you want to use it to guide clinical judgments? There are probably very many ways to address this, but one avenue that we've been thinking about is targeting parameters in the model that are based on group average laboratory data to describe aspects of circadian physiology that we know do vary substantially between individuals. So one well-explored parameter is the intrinsic circadian period, or tau. The average length of 24.15 is used in the model, but as we can see here from data from Dr. Seisler, there's considerable variation between people in the length of intrinsic period, and we know that that can explain variation in phase angle of entrainment, and it has been modeled previously. So it's a likely source of physiological variation that's not adequately reflected in the model. And then another consideration is variability in light sensitivity. So we're seeing increasingly, including from this study from Andrew Phillips and Sean Kane's group, that there's huge individual variability in how sensitive people are to light, particularly to lower levels of light. And this variability is not currently accounted for in the oscillator model, which assumes everyone responds to light in exactly the same way. So while tau isn't a particularly practical parameter to measure, you would need to do a forced asynchrony protocol that would take many days. Light sensitivity we think might be simpler to measure. So for example, looking into pupillary measures or other metrics like that. So we think that targeting parameters in the model that modulate light sensitivity might be a more feasible way of individualizing the model parameters to improve phase predictions. So to look into this, we can take our standard model of the circadian clock. We're feeding in inputs of light data over time to predict circadian timing. And we can vary parameters in the model that we think vary between people. So we can alter the length of the circadian period. We can make it shorter or longer. We can also alter how sensitive the model is to light. So in particular, in this case, we looked at two parameters that changed the shape of the dose response curve. So how sensitive the model is to light at lower levels, and changing the shape of the phase response curve. So how sensitive the model is to light that causes phase delays versus phase advances. So we've done this using a data set collected in a group of healthy individuals that were on a diurnal schedule, so sleeping regularly at nighttime, where we had 3 weeks of continuous light and sleep monitoring by wrist actigraphy. And this was our input into the model. And we can then optimize the model for each person, fitting our tau parameter and our 2 light sensitivity parameters to get optimal Dilmo predictions for each person using least squares estimation. And we can compare these predictions to the model accuracy when we use the default parameters and also to salivary Dilmo as well. So we first conducted a sensitivity analysis to assess the impact of varying each of the 3 parameters within physiologically reasonable ranges on predicted Dilmo times, really to understand the impacts of these parameters and make sure that they're suitable candidates that are going to have an effect on phase. So on the y-axis here, we have our model predicted Dilmo for each individual based on their measured light exposure. And first here, we're looking at the parameter P, which is our dose response curve. And we can see that if we vary that parameter, our median predicted Dilmo varied by about half an hour. And it varied by over 4 hours when we varied our parameter K, which is our phase response curve. And you can see that increasing values of K weighted towards a phase delay. So the model was systematically predicting later phase, and going the other direction was biasing towards a phase advance. And when that parameter was in place, we did see systematic phase advances. And then finally, we can see a very similar clear variation in predicted Dilmo when you vary tau. So these data are showing that changes the parameters that modulate light sensitivity in the model is producing meaningful changes in our predicted Dilmo times. And changing K produced a similar change to tau in quite a clear linear pattern. Changing P on the other hand, so our dose response curve over here, produced smaller overall changes and changed predicted Dilmo times in different directions for some participants. So larger values of P resulted in an earlier predicted Dilmo for some participants, but a later or more variable Dilmo prediction for others, depending on their particular light exposure pattern. So we interpret this as an interaction of P, our dose response curve, with the light exposure pattern that people were getting. So that if you were less sensitive to light, this could result in different predicted Dilmos depending on whether there was more or low intensity light in the morning or the evening. So now that we know those three parameters can meaningfully affect our phase predictions, we can look to our parameter optimization. So first here I'm showing you default model predictions. So I've got the measured salivary Dilmo along the x-axis here. So there's 3 from each person. And then we've got our model predicted Dilmo. And what we can see is that our model is predicting later Dilmo on average than what we measured. And also that at the individual level, we're not doing too well. Our R-squared is only 0.2. And our mean absolute error is about an hour. So this is quite typical of what we see when we're using the default parameters. Looking now to when we optimize all 3 parameters for light sensitivity and tau, we improve the model accuracy by 73%. There's huge improvements at the individual level. There's a really strong positive relationship between predicted and salivary Dilmo. We've got an R-squared of 0.91. 78% of Dilmos are predicted within half an hour of their measured Dilmo, and 97% are predicted within an hour. So well within the range that we think would be really useful at a clinical level. That accuracy is greatly improved with optimized values for each person. When we optimize just the light sensitivity parameters P and K, our model accuracy improved compared to default by 57%. Our mean absolute error is just under half an hour, and we've got a really strong relationship there with salivary Dilmo. And these are very similar improvements compared to optimizing just tau, which improved model accuracy by 58% and a similarly strong relationship with our measured Dilmo. So representing in both of these cases really a clear improvement in accuracy at that individual level. So we think this is really promising because from an applied point of view, it's probably going to be easier to measure something like light sensitivity using pupil measures or even a melatonin suppression protocol compared to measuring tau. So we think it could be quite a fruitful target going forward. So to summarize so far what we've talked about, hopefully I've convinced you it's important to measure circadian timing in humans as broadly as possible, both for clinical reasons for diagnosis and treatments, but also for research to better understand circadian disruption across a really broad range of contexts and how it contributes to disease. We've also talked about measuring marker rhythms like melatonin in the laboratory and at home. And while this is expensive and it is time consuming, I do see a lot of value of continuing to do this where we can. I hope I haven't made this seem impossible for clinics. A parallel that I think is useful to consider in the sleep field, people will regularly go to a hospital or a lab and sleep overnight covered in electrodes and wires to diagnose their sleep apnea. So really going in for a phase assessment shouldn't be too dissimilar. But there are limitations in what we can do with these methods. It's not particularly suitable for real-time, long-term tracking of circadian phase dynamics, which I think we need to understand more the long-term trajectories and interactions with light and health, as well as for guiding our chronotherapies. We've also looked at how we can use wearable data and mathematical models to track phase as a practical alternative. And while a lot of the methods are being developed, not so many have been broadly validated. Our best approach so far that has been best validated is an oscillator model. It predicts changes in phase based on light input and has been validated against melatonin in quite a few real-world contexts now, including challenging cases like shift workers, but it does still have trouble simulating the variability we see between people. And so I've also shown you some work that we've been doing exploring how light sensitivity combined with real light patterns can improve individual level accuracy and help explain that individual variance that the model's not yet capturing, with improvements that are comparable to fitting tau and potentially much easier to measure. As often happens when we play around with models, this work has generated some more hypotheses for further experimental investigation, particularly about how or where in the system differences in light sensitivity might manifest. So we've made some assumptions with the model parameters that we chose about how differences in light sensitivity might work, but we do still need to do more experimental work to find out how these differences relate to phase shifts and at what point in the system we might be able to measure it. We also need to map model parameters to simple measures that we can easily collect in the clinic. So at the moment, our optimization is really a case where we can find the optimum fits against known Dilmo measurements for these people, which you won't have if you're faced with someone in the clinic. So we still need to determine how best to optimize the parameters a priori. And it might be that we can optimize model parameters based on physiological measures or even indirect measures such as sex or age or medication use, or to optimize for different clinical populations. So I'm really excited to see where we can go next with this problem of exploring how we might prospectively modify approaches to improve that individual level accuracy, and to build this into more real-time prediction infrastructure to really fit in with a tool that can support diagnostic and treatment decisions. And finally, with my remaining little bit of time, I wanted to take a bit of a broader look at the quest to develop a tool to track circadian timing using simple wearables and what we need to do next, which in my opinion is much wider validation. So the pathway, as I see it, is you develop a model, whichever type of model that you want to develop, and then you validate it. So you ask, how well does it measure circadian phase? You look at the degree of alignment between marker rhythms like melatonin and the model output. And then we move or look towards implementation. So using them as tools in applied settings or in clinical populations to inform diagnosis and timing of chronotherapies. And at the moment, we're very much in the development and refinement phase with a bit of a bottleneck, I would say, at this validation stage. So often it's maybe more exciting to develop a new model, especially with exciting new approaches like machine learning. And so lots of different approaches kind of appear at this development stage. And then if it's validated against a good, reliable phase marker, it's often only in cases with really good alignment between the model inputs like sleep and endogenous circadian timing. So it's not really a dramatic challenge to the model testing it in that way. So we don't really know if they'll work in populations with circadian disruption like shift workers or across clinical populations, or in people with different medications that might alter their system as well. So personally, I think it's really important that we put a lot of effort into validating the models broadly. So with much broader demographics, more phase angles of entrainment, across clinical populations, across different medications, different comorbidities. And really, to do this, we need to be collecting very large and very varied data sets that also have reliable phase markers that we can use to assess how accurate the models are. And then the next steps are to look to implementation and using them in applied settings or in clinical situations to track phase in ways that we haven't been able to and in understudied populations. And so by this, I really mean developing a tool to track circadian timing that can be used to guide therapeutic decisions or chronotherapies, or to track the impacts of circadian timing or disruption across much broader populations than what we're able to do now with our more lab-based measures. And this includes across medical conditions broadly. There are people doing all sorts of wonderful work building the infrastructure for this kind of thing. So what I mean there is developing approaches for real-time integration of the wearable data to track changes within a person and integrating that within app interfaces. And also, I think there's a lot of work being done and to be done still to decide what to do with the model predictions. So there's lots of development and testing that we need to do here, both for developing useful interventions. So things like working in co-design, working with behavioural specialists across different populations to work out what is going to be useful, and then how we can integrate these kinds of tools in the clinic and in the workplace and in different settings. I think there's also a lot of experimental opportunities and work to be done determining what the optimal circadian administration window is for chronotherapeutics across medicine. So for example, in cancer, we see a lot of benefits of chronobiologically timed chemotherapies, and this is coming through in a lot of different medical conditions as well. And really testing how these modelling approaches can be useful for this kind of precision circadian medicine. And to do this, we really need a lot more data in these cases to validate the modelling approaches. And we also need to think about what our acceptable margin for prediction error is, which is likely something that we need to do on a case-by-case basis. And then finally, I also think this kind of approach can really open up the scale of the studies that we can run to help understand the role of circadian disruption in the development of disease. So we're often quite limited to small studies, and having much more practical tools to track circadian timing can really expand our horizons there as well. which is already happening to a degree in the UK Biobank dataset, linking light and modelled phase to different health outcomes. So I think there's a lot of real potential for when we're happy our approaches are sufficiently validated to take this quite far across circadian medicine. So I will finish up there. I'd like to thank and acknowledge my mentors and collaborators contributing to the studies I showed today and also to future ones that we're working on. And I'll put in a quick shout out to the team at my new academic home at the University of Melbourne, where we're just now building up our lab for circadian and light-based studies. So please reach out if you have any interest. Thank you.